Okay. Good morning, everybody. Okay, maybe before we start, just brief introduction of what AIC is about, okay, sorry, just to make the screen a little bit out of the way, the attendees. Okay, next slide, please. Okay, this is briefly what we're going through today in the AIC, what we are, what do we do, some of the challenges that during COVID that we face, some examples of the tech implementations that we have went through, and perhaps some of the opportunities offered by technology is outreach, and perhaps a little bit of sharing as to the innovation and the process of innovation that we have gone through. Okay, next slide, please. Okay, AIC, what do we do? Essentially, this is what we do, summarized into one slide. We connect seniors to understand their needs and help them to stay active. We connect to the caregivers, provide them with information and support so that they can care for their loved ones, right? We connect people to care services as well as financial support, right? As well as working with our key partners like St. Luke's, which is my next speaker as well, right? So during COVID, I think a lot of times we spend, besides outreach to the seniors, we spend a lot of time working very closely with the partners to make sure that our seniors stay protected as well. Okay, next slide.
Okay, Gerard, I think your mic has some problem. Maybe you want to put it closer to you.
Can you hear me? Hello, hello?
Yes.
Okay. Okay, shall I continue? Yeah, so these were some of the needs that was created that we saw during the COVID situation. Of course, the meme on the right, I think every one of us should have seen this in one way or another, right? Who led the digital transformation during this period? It was not the CEO, it was not the CIO, but it was COVID-19 that made us suddenly wake up and realize that the digital transformation was something that we had to embrace. Yeah. Sorry, I'm just hearing an echo of myself. I don't know why, but yeah, somebody's speaker may be on. Yeah. So during the COVID-19, early on, we realized that we needed to protect the seniors, and therefore bubbles had to be created. So essentially what happened was that very, very early on, we actually began to disallow, as a system, caregivers, visitors, and volunteers into the care facilities. So this will be where the vulnerable seniors are staying. So this will be facilities like nursing homes, right? We suspended activities at the senior care centers, and this was all done with the intent that we want to keep the seniors, those who are mobile, to stay at home, and then those who need care in the nursing home not to be exposed to visitors from outside, right? Then the subsequent issue came about where we realized there was a need to continue engagement with the seniors, right? We need to support their psychosocial needs, and so that they don't become what they call disengaged. And then concurrently with the raised infection control requirements, right? That has an impact on the staff, right? The staff now not only cannot rely on volunteers to their support or cannot rely on visitors to help with some of the daily care, they also have to manage that raised infection control in case if there is an outbreak, or basically just to minimize any issues that might happen. So this raises and puts a lot of strain on the resources of the homes that are running operating during this COVID situation. Yeah. So next slide. So early on, we also realized that the tech could be helped in certain areas. So basically what we did was that we kind of opportunistically, we realized that there are certain areas like operations and activities and perhaps monitoring are some areas which we could look at to help address some of the needs that is faced by our sector during these challenging times. So things like the contactless temperature scanning, so that we can minimize the number of staff handling the temperature scanning, whether or not would robotics UV disinfection actually work. How do we have an activity scheduling system to be put in place when activities gradually resumed, right? Or even for the seniors, right? How do we address their mental well-being? How do we connect the seniors back to their loved ones? And then therefore we felt that certain things like tablets, meeting collaboration software, eldertainment systems, robotics could be some technologies that could be used to help with the engagement of the seniors. And of course, we've also explored the possibility of implementation of elderly monitoring through panic buttons. But yeah, that's something that I'll talk a little bit more later on. Yep. Next slide, please. And we were very grateful, to be very honest, during this period of time that the corporates came forward as well to help. Thanks to the volunteers or the corporate donors below, actually the whole list there, they actually stepped forward, and through them, we actually help our ComCare providers through the implementation of not just these technologies, but also care for staff, through the various charity funds that we have put together during this period. So basically, we had like 4 funds that help the sector: the Stronger Than Before, Stronger Together, Ready Together, and Stronger at Home. And basically, these funds were intended to put in place to support our ComCare providers that were hit by the COVID-19. I'm sure you have read it in the papers. There were a few, right? And then to strengthen their system resilience and to support service continuity, because the seniors still continue to stay there, right? And then to show appreciation and concerns for the staff who are working in the community care sector, and as well as to allow them to continue to provide services to the seniors. Yeah. Next slide, please. So this is some examples of some of the things that we actually mentioned, and these are the physical devices. I will elaborate a little bit more on the contactless temperature scanning device. It's a little bit different, the needs case and the whole journey behind it. I will share a little bit more. Activity scheduling was something that we again felt that was very important, because I think we realized that for for example, the senior activity centers, the seniors typically come and go, but with the social distancing requirements that were put in place during COVID-19, it became pertinent that certain seniors could only make use of the resources at that point in time. And this is again creates a challenge for the centers who are operating their facilities. And the last example is actually the little the blue robot that you can see at the side. We actually trialed one of these UV robots to determine the effectiveness of this UV disinfection. If we realize early on during COVID-19, there were many articles in the papers that actually spoke about UV disinfection, but it does present some challenge. To be very honest, I mean, in the nursing home environment, it's a 24/7 environment, whereas, for example, in the commercial office space, and we have seen the UV robots being deployed, right, by commercial vendors. Those spaces are not used, or retail spaces, right? Those spaces are not used at night. So the robot has a free rein to move around and to expose the surfaces to UV infection, and therefore, further disinfect the space. But in a nursing home environment, typically the challenge is that it's operating, and then therefore there's actually labor impact to move seniors from one place to another while we allow the robot to do what it needs to do, right? So these are some examples of how tech can help, but yet we need very clear understanding of processes to make sure that the tech actually helps with to augment and achieve the intended outcomes of the tech, and don't becomes an impediment and create new additional work for everybody. Yep. Okay, next slide. So for this slide, I'll be sharing a little bit more on some of the tech that we have kind of tried and put in place during the COVID-19. We realized that connecting back to this, from the seniors back to their loved ones, was absolutely critical. And thanks to the donations, and even within AIC, we to be very honest, we recycled some tablets that we have in a way of like saving the environment, and we actually gave it out to all the ComCare partners in Singapore. And then they actually use the tablets to connect the people who are staying in the nursing homes back to their loved ones. But just to share some insights, interestingly, some of the seniors actually feedback, and this came from different nursing homes, that why my loved ones cannot come and see me anymore? Why do I have to see my loved ones through a TV screen? Okay, they can't quite differentiate between a tablet and a screen, right? So they say, why do I have to see my loved ones in a TV screen, and am I being abandoned? So these are very interesting insights, which we think that some of this, our seniors today, based on their demographics, right, tech adoption or tech acceptance is something that we really need to think about. But of course, going forward basis, the newer demographics, who are people who are today a little bit more comfortable with tech, this might not be so much of an issue. We also realized that with the operations, the need to split zones within the nursing home, suddenly meeting and collaboration software became quite critical. we work with Microsoft for this, and they have kindly also donated their teams out, like the license copies of their teams out to the sector, so that they can actually connect, on top of the typical free solutions. Of course, we all know that Zoom, the platform that we're using now, became a huge thing, right, during this COVID-19. And the fact of the matter is that connecting digitally through channels actually became a critical infrastructure for businesses to continue. But at the same time, it also allowed for our seniors to continue with their connections back to their loved ones. We also realized that we needed an elder entertainment system. The nurses today are running clinical ops. And then therefore, if the seniors are prepared and connectively able to, if we have an elder entertainment system that's installed into the device, they can actually use that device and be able to manage their entertainment. Again, this is not for everybody, but we realized that the seniors that were exposed to this, some actually took it on quite well. The fears that our clinical staff that, for example, that they need to become the help desk for IT, did not really materialize. I think that was, again, another interesting insight during this period. Perhaps I think Kenny can share, Prof. Kenny can share a little bit more in their insights later on as part of this implementation. And the last one, I mentioned a little bit about elder monitoring. I think this is actually a very interesting device. It was unfortunate that in the end, we couldn't quite implement this, but it does give a certain opportunity to, it's a passive device that relies on low frequency radio transmission. And it does, in a way, perform as a panic button of sorts, whatever the reasons why we couldn't implement it, this company actually managed to roll it out at the dormitories during COVID-19, and it was successfully trialed and proven successful that if the seniors needed, or if the workers needed help, they press the button, the data is actually collected into the phone. And for seniors, these buttons could actually be even mounted to like doors, their fridges, and actually provide some sort of elderly monitoring, whether or not the seniors are still moving around within their home. So these are some of the examples that what we have done. Okay, maybe go on to the next slide. Yeah, so I think as what Colin has mentioned, we are not post-COVID-19. We have not lowered our guard. We are just being very fortunate that our community cases are zero or very, very, very low. And therefore, we need to continue to adapt to this new normal with this increased reliance on technology. The impact on our community care providers is how would they look at tech and internal process changes? The tech cannot be just layered on top of their existing processes. They need to embrace, which is not easy, right? And then for the loved ones, the clients, then the question is how could the tech help them improve their care outcomes? And then open up new ways of interaction, right? We also saw and read in the papers that during this period of time, there were a lot of seniors that took on to WhatsApp or Telegram, where they can then suddenly realize that their mobile devices had a new meaning, right? Beyond just calling each other. And one of the key things that we also kind of figure out in the conversations with our ComCare providers is that tech has to be sustainable, such that it doesn't become white elephants. And to be honest, while we were pushing very hard on senior engagement using tablets and video consulting as a platform, there is a little bit of a slip back since we have this phase 2, right? Phase 1, phase 2, where face-to-face is a certain amount of face-to-face care is actually re-allowed again. And to be honest, it goes back to the earlier point, which is about process changes. It is a whole spectrum. It's not just about the introduction of tech at a specific point in time. The intervention for tech has to be the entire process chain, from the care people who design the care, the people who operationalize the care, the people who are receiving the care, the caregivers themselves who are supporting, and being open to receiving the tech, right? And all kinds of interesting, and the whole process chain. We have interesting situations where we wanted to deploy tablets, and then we realized that the senior's home doesn't have internet connectivity, for example, because internet is not quite important for them. So these are those challenges which I think underlie what they call our tech adoption journey. Yeah. Okay, next slide. So this is again just a quick example of how new channels of delivery happens. I think the ADA has been rolling out certain programs and riding on the Mosaic, which is one of AIC's platforms. And perhaps, I know I'm running out of time, but I would want to share a little bit on my second last slide, which is innovation, the journey of innovation. Last slide, please. Next slide, please. Sorry, the previous slide. Okay, then for this slide, we just want to share something that we have worked very closely with the rest of the government. I think for the most of us today, when we go to a shopping center, we see the very nice thermal scanner or contactless thermometer. It does cost quite a fair bit. It's about a few low thousands of dollars. And during the peak of COVID, it was like $3,000-4,000. Right now, it's like about low thousands of dollars. So the problem statement for us was that how do we do a contactless temperature scanner that is as cheap as possible? So GovTech, of course, being the technical person, the A team of present generation, they took apart thermometers and then decided to build parts and see how they can, allow seniors to measure their own temperature. And the problem statement is just measure temperature. It's not to integrate with safe entry. I think that's a separate conversation, which I believe everybody is asking about. Yeah, but the problem statement was, can they measure temperature easily by themselves? Then, of course, when they work with us, we brought the devices to the ground, we trial it. We realized challenges include things like, is it sensitive? How close you have to put your forehead? The digital panel is too small. They can't see the readout, right? The height of the device was wrong. The seniors had to bend down. What about wheelchair users, right? And all this the iterations that we have gone through to build a final device. And you can actually see the pictures that's from the left to the right. The final device is quite different. The earlier devices were on the left. The final device is a very nice little device. It's not easy, right? We have to manage through the iterations, and then this where innovation happens. It is all about teamwork, and it's all about willing to experiment. We really thank those partners that work with us on the ground, the various Comcare providers as well as GovTech to actually make this thing possible. Just to share, we managed to roll out, I think, close to 390 devices across all Comcare providers in Singapore for this low-cost temperature measurement solution. Yep. With that, I kind of come to the end of my session and sharing. Thank you. As what we say a lot in AIC, we are together, we will get through this, and please do not let our guard down during this COVID period, and maintain our safe distancing and keep our hand hygiene going. Yep. Thank you so much.
Thank you very much, Gerard. So it's very interesting for AIC to share with us the implementation that's on the field. And well said, the tech has to be with clear purpose, looking into the user experience to be intuitive so that it won't be a white elephant and the seniors can adopt it easily. So next we have Dr. Kenny Tan. He will be sharing with us what St. Luke Eldercare has done in the technology transformation during this period and what will be his plan for post-COVID or even the new normal. Prof, for you now.
Thanks, Wylin. Can you hear me?
Yes.
Okay, let me just do a quick share. Okay, thank you for the invitation to share with everyone. I want to take this opportunity to also thank AIC and Gerald. We are beneficiaries of the GovTech contactless thermometer, but we are also people who complain that it's too high, too low, and not very applicable. But what he said was very true. It's been a wonderful learning journey, pain, but I think there are a lot of gains because we actually learned how adaptable our staff and our elders are. So very quickly, just a few slides to share with us who St. Luke's is, just to set the context of how COVID has affected us. So our vision is to transform community care, and we are a Christian healthcare provider, which we want to enrich lives in the community. So we always ask ourselves, who are our communities? So our communities are our clients, our elders. They also include our caregivers. They include our community partners, who are a lot of them are our volunteers, and also our care staff as well. So we have actually 4 communities, right, that we want to reach out to as a mission. So very quick slide about our services. We are basically primarily center-based, providing dementia, daycare, maintenance, daycare, as well as day rehabilitation for elders across our 20 over centers in Singapore. We also provide center-based nursing as well as weekend respite, and we have also moved into home care as well as residential care. One of our nursing homes, our first nursing home actually opened in May 2020, right smack in the midst of COVID. So there were amazing learning opportunities during that period. So this is just a slide to show our service footprint. We are island-wide. we will be also operating Active Aging Hub in 2021 in Bishan. And we are in the midst of planning for that. And we're also wondering how COVID is going to change the way we engage our communities. So COVID-19 affected us in ways we never saw or expected. And during circuit breaker, we actually had to close all our centers except for one for about 2 months. And like I said earlier, we had a nursing home opening in May 2020. And during the circuit breaker, all our staff, all our elders had to stay at home. And we serve about 3,000 to 4,000 elders. And just a stroke of a pen, everybody had to prepare to go home and stay there for 2 months. And impact on our services, I think as I shared earlier, the slides, we are a very on-site service, right? In the center base, even in the home and residential based. And we are very high touch, being a very service-oriented organization. There's a lot of engagement that we do for our elders, a lot of direct care. So it's very labor-intensive, high touch. And we are low tech because we are high touch and on site. And suddenly we realize with COVID, it's going to end up being off site. So if not, that's not horrifying enough, we realize that our high touch service becomes in a way low touch because we can no longer reach out to them in person. And we ask ourselves, how do we then use tech? And we don't say high tech, we say maybe we go for more tech, and how that would actually impact all of us. Our concerns actually during COVID-19 were primarily our staff. We have about 650 staff. Most of them are local, and they are mature workers, median age of 50. In fact, about 25% are almost in their 60s already. And we ask ourselves, if we introduce technology, how is that going to impact adaptability? For the first 2 months when our staff were at home, could they adapt to working from home? And could they adapt to any technology that we want to introduce? And not just adapt to it, could they accept it as well as a new form of delivering care to our elders? So these are just our staff, but of course, we ask the same questions about our elders as well, who are at least 10, 20 years older than the median age of our elders. So COVID-19 actually accelerated our desire to integrate technology. I'd just like to share with you a few approaches. We wanted to innovate our care delivery to our elders. So suddenly for 2 months, our elders are at home. So how do we create virtual touch points with them? This actually started on the ground. Our staff they actually missed their elders very much. So they decided to engage the elders at home. They wanted to give them a sense of normalcy. Even though they're at home, could they create a sense of center activities in their homes? So what they actually did, they videoed snippets of themselves saying, hello, how are you? Taking videos of rehab exercises and actually sending it to the elders just so that there was some form of engagement. And we found that different centers were actually doing it. We kind of consolidated it. And for about a month, we actually created a Stay Home with SLEC daily YouTube video that we put on Facebook Live from 10 to 11 a.m. That was a morning talk show kind of an approach, just to give a sense. You tune in and it's almost like it's the center activities once again. So we did stay active exercises, we did sing along sessions and reminiscence activities. So that's an example of one of our daily Facebook videos. So we put it on Facebook Live and people could just tune in. So our younger staff decided to take on the role of a top host, and I think they kind of enjoyed themselves. But truth be told, our communications team were very stressed because it took them many hours to splice together a 1-hour program. And they did that for 1 month, after which they quite flagged and said, don't do. And thankfully, then circuit breaker, stopped and everybody could come back again. And our rehab staff, they they videoed the exercises, which were then beamed, on a daily basis. So the elders could then watch and do from home. And what really helped was familiar faces. The elders could recognize, from different centers, they could recognize that these was the staff that they were familiar with. So we thought the younger folks, our younger staff, were the ones who were enthusiastic, but surprise, surprise, we actually found out that our more mature staff also were very, very sporting, so they put on sunglasses, they really had, a ball trying to engage as well. So this was a very good opportunity for our staff to remain engaged in the care of elders, and a chance for them to still stay connected in a very different way, but the approach was the same, engagement. And we also did reminiscence activities with them as well. So we did that for about a month, but then we also realized that this virtual touchpoint was very one way, right? You just sit there and you just watch. And then we decided, okay, shall we do a bit more home-based learning? We said, don't just stay home, but let's stay connected with us. And we used Zoom sessions, small group Zoom sessions with elders to maintain social connection and to maintain daily rhythm activities. So we used Zoom to connect with the elders. So staff were able to connect with elders with the capability in the home to stay connected. So after probably in July, when circuit breaker kind of ended and we were able to reopen our centers, like what Gerald also mentioned, there were a lot of restrictions on volunteers, and it was pretty stressful really, because we depend a lot on volunteers to help us to engage our elders, and of course we said let's continue to stay safe with SLEC, but this time we will try to use Zoom, because we had opportunity to learn for 2 months of how to use Zoom for engagement, and we took time to encourage our volunteers to Zoom in with us. And we were very fortunate to have volunteers who were very sporting, and especially the younger ones, the children, childcare. The teachers actually managed to put them on Zoom, and they Zoom live to our centers. And that created a sense of that connection. And our elders were actually pretty engaged in some of those sessions. I call it blended Zoom because it's not just watching a screen, but for some of the volunteer activities, we were able to do it blended. It's not just watching a video of kids singing, but there were activities that could be done at the same time during the Zoom as well. And when there were gifts as well, so it was not just watching, but very tactile and engaging as well. So beyond just engaging our elders, we realized that in our other communities, we talked about our staff, our caregivers, our volunteers. We needed to continue to engage them. We were very concerned our staff were at home for 2 months, and how they would feel. The psycho-emotional mental well-being was important to us. And our need to continually engage our volunteers to say that, okay, out of sight, but not out of mind, to continue to remind you that we are still around, and do remember us, and watch out, for when we can meet up again. So we did a lot of outreach to staff during those 2 months at home. Of course, Zoom, I think, was used. We had one Zoom account, and then we multiplied it with, and then we ended up with more than 10 Zoom accounts. And I think we actually have a lot more, but different departments could then use Zoom to engage staff. So we decided we will take the 2 months to engage staff from every center. So we had more than 500 staff who were at home. So we did personalized Zoom with center staff. And that was also a chance for our staff to get used to technology. It was almost like a soft launch to technology for our staff, and we decided we will also implement copy chats with the CEO. While previously it was tough to get to me, now it's just a press of a button, you can have a copy chat. We wanted to order copy and send via Grab, but we decided it was too tough, so it was virtual coffee instead. You make your own coffee and we chit chat over Zoom. But what was interesting was we were able to do staff training via Zoom. because we are so decentralized, it was previously difficult to get staff to come to our headquarters in our training center for training. But because by just circumstances, we actually put up a lot of modules via Zoom. And because staff were at home, they have gotten used to Zoom. We actually clocked in more than 6,000 training hours in one of the months during circuit breaker. And we were pretty amazed because staff actually were very willing to learn. They were hungry to learn, but because of work, they weren't able to get access to training. One of the things we did via Zoom was we introduced work-life balance. We did talks on mental well-being, and actually, to our surprise, for the one in April 22nd, the English, we had more than 350 staff actually signed up voluntarily because they wanted to hear more. And when we did the Chinese bilingual version, another 150 staff signed up for that. And we were pretty surprised because we thought the more mature staff would not be open to it, but they actually were. So we also decided we needed to outreach to caregivers and volunteers, and we also use Zoom to do telehealth support for caregivers. And interestingly, because of technology, caregivers could Zoom in. While previously it was tough to engage them because they were working and very hard to get them on weekends. But we did this, they just came in for an hour and we were able to reach out to them. We were able to engage our volunteers for live stream talks. Our dietitian, some of our allied health colleagues were very, very enthusiastic. They had a lot to contribute and to give. So we were able to engage a lot of our volunteers through our talks as well. And we were even able to do art therapy workshops with volunteers. All this in preparation for when the restrictions will be lifted and we get our volunteers to come back in. So we are making use of this time to continue to equip our volunteers, caregivers, and staff. So very quickly, what was our learning? We thought that our staff and our elders won't be able to adapt, but this is something. Sometimes we put on blinkers, right? We think older people are not adaptable. But one thing I learned, they are survivors, and the survivors of World War I, World War II. They will survive SARS, they will survive COVID, and they are highly adaptable. We need to recognize that and not assume, right? And acceptability, yes, sometimes by force of circumstance, not only by force of circumstance, but just making things available, people will generally accept, and it does take time, of course, but I think one of the things that we really looked at is availability, and this is quite connected to what Gerald was talking about. We can provide the programs, but if the hardware is not available, if there are no iPads, there are no laptops, it can't happen. You can provide the iPads, but if there's no Wi-Fi, it won't happen. You can provide the laptops, you can provide the Wi-Fi, but if there's no one to turn it on for them at home, it also may not happen, right? So these are some of the things that we're continually learning: adaptability, acceptability, as well as availability. So we are moving now into online training. So we are going into a proper online platform for our staff to continually learn, as also use that platform to hopefully engage our elders and our partners as well. So COVID has accelerated adoption, and we are moving into that. So I end my presentation, but for those of us who are interested, join us in our care journey. You can find out more. Click onto our Facebook. I think our watch party, the 1 hour program, is still online on Facebook. So thank you very much. Back to you, Eileen.
Thank you very much, Prof. Kenny. So it's really interesting. You pointed out one important point, which is besides the technology, the content is very important to engage with the caregiver, with your staff, with the patient himself. So certainly, I think to be adaptable, elderly actually at this point in time, we shouldn't assume that they couldn't use tech. Yeah, so this is a good point that you raised. So we have a few questions already coming in. So I'll leave the question to the Q&A session, which is after Dr. Ravi's sharing. So keep the question coming. You can enter it through Zoom. The Q&A tab is below your screen or from Facebook Live. So now I'll have Dr. Ravi from Tan Tock Seng Hospital to share with us what is the hospital innovation and what has been done during the COVID and what will be the future roadmap for geriatric and also to care for the patients in the community. Dr. Ravi, over to you.
Thank you very much. And thank you for the opportunity to speak today. I must say that my previous speakers have actually covered a lot of what I'm going to say, but it is truly impressive how far we have come in terms of supporting the elderly through the use of technology and how working together has enabled so many services that previously were only provided as face-to-face services. And I think this is just a sign of the fact that I truly believe, as what was mentioned earlier, that the elderly are ready to embrace the technology that can be used to help them navigate through the healthcare journey that they have. Anyway, so I'm going to talk a bit about what's been happening at the institutional level. So it's more directed at the patients, but we'll see how things go. Basically, I'm going to be talking about the Institute of Geriatrics and Active Aging. And I think we'll touch upon something that the others have talked about, which is digitizing the healthcare journey. Some of the initiatives that have been occurring at Tan Tock Seng Hospital and IGA, and you know, some of the things that might be hopefully might happen in the near or distant future. So geriatric medicine in Singapore has obviously had a long and interesting journey. And this slide is just basically to show you when IGA was set up, as well as the Tan Tock Seng Center for Geriatric Medicine. We, of course, have a large focus on the care of geriatric patients. And in fact, we were the first to set up a geriatric medicine department in Singapore. Tan Tock Seng is actually a household name, quite familiar to most of you, I'm sure. So I'm not going to, don't need to touch on what we do, except to say that it is a large multidisciplinary hospital. And as I mentioned earlier, we do have significant geriatric services. Now, the Institute of Geriatrics and Active Aging, this was set up basically to be the leader in geriatric research and education. And this is our vision. This is the icon or the symbol of IGA, and it's basically, you know, you can imagine the strength of a tree and how that actually becomes a symbol of a long-lasting and stable support system through which we can, you know, grow and at the same time provide a variety of different services that would eventually support the elder population within our country. So what are some of the key pillars within geriatric, within the Institute of Geriatrics and Active Aging? So basically research, innovation, and education. What we're trying to do is to work with a variety of partners to come up with solutions that can help the elder population to live better in the community, not necessarily those who are sick. It's about living well, aging well, and being able to continue to manage and be truly functional and independent within the community. And of course, we also have education sessions that touch on a variety of different topics delivered by our specialists and our partners, which any individual can actually sign up to on the website. And I'll give you some of these details later. So I'm going to be talking a little bit about the management of an older patient with complex care needs. And as you can see, there are a variety of different things that we need to make sure that we cover in order to ensure that the individual remains well in the community or the home, which is actually one of our key targets. right? So care coordination is crucial, and a lot of these things used to be done face to face, and obviously COVID has come along and maybe changed some of this. So one of the things that we have realized is that, and this is not something that occurred with COVID, we've been talking about this for a few years now, but obviously COVID has accelerated this. We need to digitize the healthcare journey. And that means that we give our individuals basically access to healthcare remotely without having to physically turn up to an institution. And this might mean teleconsultations, it might mean telemonitoring, but it's not just about healthcare, even providing the coordination of care and things like if they are not ill, how do we maintain their health in the community? All of these things are basically part of what our overall vision is within Tan Tock Seng and IGA to deliver care to the community, this time with the use of technology. So as was mentioned earlier by the previous speakers, people have a misinterpretation of tech adoption among the older adults. And yes, I know that tech can be a little bit difficult to understand, even for some of us young people, although maybe I'm not that young. But the point being that actually the elderly now are embracing technology in significant ways. Now, these are US statistics, but I think this is an example of how the rest of the developed world is actually responding as well. We've got a large penetrance of smart devices, and many of our elderly are actually using these smart devices quite effectively. So we do have that, that market as such where we can roll out digital services to our elderly population. So some of the initiatives that have been happening at TTSH and IGA, obviously telehealth has been a big feature now. We talk about teleconsultations, remote monitoring, even telerehabilitation. We've done home medication delivery, although this is again something that had been going on prior to COVID. With COVID, it's been enhanced to a huge degree and embraced by our patients. Of course, home visiting, again, something that was happening previously, but now expanded. We do things that help individuals stay out of hospital by predicting their readmission risk and then trying to intervene while they're still at home or in the community, and thus reduce the need for an admission for care. We are trying to share clinical data with relevant individuals who are caring for our partners through the use of electronic medical record systems. And a new initiative that we've recently introduced is something called Clinic Without Walls. Again, I'll go through some of these details in a bit. So this is a great slide. It shows how significant the adoption of telehealth has been since COVID came aboard. So I remember I've been trying to run telehealth services for the past 10 years, and it has truly been plodding along, not because the technology wasn't there, but because I think it was difficult to convince people, especially in Singapore, to stay at home and use technology when they could just take a cab to or a bus to the hospital that was 10 minutes away. Obviously, with COVID, things have changed, and this is actually an encouraging sign because it shows that when it came to the crunch, we were able to deploy, and it was not a case of not having the infrastructure in place. So teleconsultations and telecollaborations are now being used extensively across the hospital. We've got more than 50 ongoing clinical services that are currently being delivered remotely. Of course, many of them launched after the COVID-19 issue arose. But the point being that most of them intend to continue even after the COVID pandemic settles down, because we've realized that this is what patients want, they benefit from it. And in fact, it is something that can be delivered in the majority of use cases. Tele monitoring is also something that we, again, have been trying to run for a while, and this is expanding in scope. As you can see now, there's so many more devices that are available, a whole host of different parameters that can be captured remotely. And truly, we are living the age where we can perform remote physical examinations on our patients and gather a lot of information about the state of an individual, which can help with care decision making, which is something that I guess we probably didn't have even 10 years ago. And speaking to someone over the phone and getting maybe the symptoms takes you so far, but the ability to capture some truly discrete information about the patient's health status transforms the way that care can be delivered. Obviously, home visiting is still going on, and this has expanded in scope as well. And of course, as you can see, I have to always show that I'm also working because I think my boss is watching this. Yeah, so I do some home visiting sometimes, and this is the proof. I talked earlier about how we're trying to keep individuals out of the hospital. Basically what we do is that we are using an AI algorithm looking at some key predictors of readmission risk. And all of these go into a scoring system that allows us to determine the risk of an individual coming back to the hospital after a discharge. And those who have a high risk, and it's not because of something that the patient does, it's a variety of different factors, which even might be transparent to the individual. But this allows us to then, focus on these individuals, to reach out to them, to sort of try to provide additional support and care once they leave the hospital. And in so doing, we sometimes preempt some of the problems that may arise, which would otherwise have led to an admission. I mentioned the Clinic Without Walls. This is something that's recently launched at our specialist center in Ang Mo Kio, and basically provides a whole host of electronic services that are available to individuals. Things like e-itinerary, e-appointments, and e-registration. So you're basically able to check in for your appointment using your mobile device, rather than having to do so when you turn up at the center. So this is quite an exciting project that's been launched by one of our teams in the hospital, and we are looking forward to expanding this further as we get more data from our patients. So there, as you can see, there's a whole host of different technologies that are available that we can actually institute for our patients. And some of these are ongoing projects. Things like medication adherence, for example. This is something we're also working on. As I mentioned, we've got various video consultation, audio consultation projects, vital signs monitoring. And at the same time, some of these things using sensors, etc. These, again, have been tried and tested in various projects. Now we are hopefully moving towards a stage where some of these can actually be operationalized. And in so doing, we would want to change the chronic disease management model. Previously, obviously, it meant an individual turning up at the polyclinic or an outpatient clinic where they then get management, and as you can see, then they end up being referred to specialists where needed, etc. The future model being that they can just basically stay at home, and everything else revolves around them. Whether it's through the use of sensors and home monitoring and analytics that determines what their needs are, and at the same time, various support systems, whether they're available in the community or virtually, would help to keep this individual well informed and also healthy in the community. Of course, as was mentioned in my profile earlier, I am very keen on trying to develop the Internet of Healthcare Things, because I think this is truly where the future is going to be in terms of the utilization of healthcare, and of course, reducing the overall needs of the healthcare service provision. So there is a whole host of things that is available. I think if you try searching Internet of Things and wearables and healthcare, you find so many things. The issue now is not the fact that we don't have the technology. It's how do we integrate all of this? You buy a Samsung watch and you pair that with an Oppo phone, for example, and you use an iHealth glucometer. They're all different platforms. They've all got their own apps. This information is all sitting in different parts of your smart device, but it needs to feed somewhere. It needs to go somewhere where AI is able to look at that data put it all together, and then either give you insight into your health status, or even give your healthcare provider insight into your health status, and through this partnership, able to keep you well or to manage your chronic disease. So in fact, recently at a talk I had, we mentioned that healthcare is no longer about the patient and provider relationship. It's now a threesome. It's patient, provider, and AI. And AI is the one that sits in between and advises the patient as and when data comes in, advises the clinician as and when patient's data comes through as well. And together we can actually help to manage individuals in the community. So this is definitely what we want to achieve. So you can imagine what might happen in the next 20 years, with all of these devices connected to the internet and providing data regularly to the patient, giving them feedback on a variety of different things that they're doing. I mean, we are already looking at our sleep patterns, for example, how many steps we take, but those are, again, something that require interpretation on our part. Whereas in the future, these will translate directly into outcomes that we are more interested in, right? We want to talk about how we can actually monitor the medications that individuals are taking and how they actually impact upon the individual as well. This is part of the personalized medicine initiative that has started across the world, in fact. And at the same time, this data needs to go to your clinician, who then has access to information as and when they need to review you, or if they need to manage some of the issues that might arise. And this, in fact, would also be available at the point of care, regardless of who you're seeing, provided you give them the access. Obviously, the responsibility and the power to enable access will lie with the individual. But the fact that you have that ability to share data with anybody that you choose so that they can provide you with more personalized care, I think would be a great step forward. And this is what we want to achieve. So basically comes to the end of my talk. I think I just wanted to let you know that there are a variety of ways that you can actually connect with IGA. Do reach out to us, and if you check out the website, you'll find that there are often interesting articles there about elder care in the community and in the hospital, as well as programs that are like educational programs, etc., that are often organized for the public. And with that, I thank you very much.
Thank you very much, Dr. Ravi. So now we know, actually, besides patient and the providers, now we have AI in between to help physicians to understand us better so that we can have more personalized care. So thank you very much for the insight. So now we'll enter into the Q&A session. So I'd like to invite all my panelists to turn on your microphone as well as your video. So I do have many questions that come in. We'll try our best to answer them. So maybe for the first question, maybe I pose it to Mr. Ravi and also Mr. Gerald Ng. As you shared about Internet of Things and also many different technologies that were deployed in the community, how do you manage the interoperability of the different systems? Do you have an issue with that?
That's a good question. I did mention earlier the fact that we're using multiple different devices, and each of them might have their own platforms, data stored in their own applications. However, I think one of the things that a lot of big health tech companies are doing are trying to integrate these different data sources into a single view for healthcare providers and for patients to be able to better manage them. In Singapore, for example, we've now got a national vital signs monitoring platform. And we've also got a central repository of client-generated data. So the movement now is that any data that is captured through tele monitoring can be directed towards this central repository of data and therefore viewed by the clinicians. It becomes device and platform agnostic. I think that would be a significant step towards being able to manage someone regardless of whatever device they use. At the same time, this data could at some point flow into the electronic medical records of the patient so that the clinicians in the hospital or polyclinic, etc., have access to it at the point of care.
Thank you. How
I
about?
think actually that's always been a very, very challenging question to answer. I think the larger intent, as what Dr. Ravi has said, that we do hope that there will be some sort of a uniform architecture that where health data can be consolidated and therefore allows for a seamless client journey. But the challenge that we have is not all devices are health devices. A lot of them are wellness devices. Therefore, underlying behind that, there are different standards, and of course the ethics behind having all this data floating around. Do we want to be monitored? Do we want to be told how healthy or unhealthy we are? So I think it's not an easy question. It's not just only Singapore grappling with it. To be very honest, in some conversations we have with equipment providers, Singapore is way too small for a common standard. We can't use Singapore as a basis to set a common standard for the rest of the world, right? For data connectivity. So I think that challenge remains with us, and therefore public education is important. To recognize that when we give our Fitbit data, it goes somewhere, right? Then where it ends up with, and whether is it end up being used against you or for you, is something that we need to journey through. It's something that, as what Prof. Kenny has said, it's a journey. I don't have an answer, to be very honest, but well, I guess first step to good health is knowing how healthy we are, and I guess knowing the equipment, having the equipment to support us is a good first step. But the rest of it will be something that I think, to be very honest, all of us are sweating over it to establish this. Thank you.
Okay, thank you. Prof. Kenny, do you have any comment for this question?
I think an issue also of coordination. I mean, the larger healthcare institutions really have a lot of data points that are very health related. But if you look at health from a very holistic point of view, it's also the mental well-being. How do you measure quality of life, the aspirations? All that actually is not captured. But the aspirations actually guide health-seeking behavior, right? And also guide whether we want to maintain and promote health, either individually or corporately, right? So I suppose there are larger questions than just the hard data, but how do we capture soft data? Like an elder that comes in, with post-stroke, we assume that we got to get them walking, and otherwise we don't ask them, why do you want to walk, right? The physiotherapist should ask, so what would you like to do when you recover? Maybe the auntie says, I want to play with my grandchildren, right? And we sometimes assume that we say, oh, I'm going to help you to put your clothes in the washing machine, and we do the treatment like that. But then maybe for them, I don't wash clothes. I want to walk my dog. I want to play with my grandchildren. So these are some of the questions that we actually don't capture in any of our systems at all. So that to me is another aspect of health, right? Yeah.
Thank you. Yeah, certainly the hard and the soft data.
Yeah.
So maybe I just continue the question for you, Dr. Kenny. So there's a question, it says, excellent initiative by your staff to engage the elders remotely. So how did you help the elders to go online? And most of the software applications are all in English. So what's your experience with the non-English speaking seniors?
So it was a bit of a nightmare because we may want to do it, but sometimes the hardware is not available at home. So we actually had to engage the family members, the caregivers. So at the center level, we have good communications with the family members, and so we actually had to engage the family to say that we've got something like this. Would you want to make it available for the elders, set it up for them? So for elders who are fortunate enough to have people at home, right, whether it's a domestic helper or even family members, they can. But we have a lot of challenge with elders who don't have anybody to care for them at home. Nobody to set up, even the iPad and things like that. So those were some of the challenges, but those with family members and helpers were available, we could make that happen. And there was a lot of coordination and communication. So with respect to the language, yes, we were very cognizant that, of course, the entry level into the program is English, but our programs were bilingual, and that's why we had two top hosts. One will speak in English, the other will do it in Mandarin and even dialects on and off. So we do realize actually we need to do that. And moving ahead for a lot of our training, for example, we have to look at Mandarin as a substantial medium of communication. So even in our Zoom training, we are doing it in Mandarin. And now when we do a proper online platform, we actually have to use Mandarin in addition to English. So that's something that, yes, we learned.
Understand. How about Dr. Ravi, when Tan Tock saying you had your home visit and your tele consultation, how did you overcome the language challenge and also the internet connectivity?
Yeah, so language has always been a challenge, but obviously we've got a telephonic team, and what we do is that before we do any home visiting, we reach out to the individuals via telephone and understand their needs, and then we pair them with the most appropriate person who's likely to be able to communicate with them. So we've got individuals speaking a variety of different languages, and I also eat of Chinese. But on top of that, I think the internet connectivity issue is an important one. We often find that in many situations, at least one individual in the home would have a smart device, and we can try to leverage on the use of that smart device to connect with the individual for basic consultations. And as I said, if we can't do a Zoom call, we can at the very least do a WhatsApp call or just a standard telephone call. Having said that, for tele monitoring, what we are trying to do with some of our individuals is to give them a smart device along with the peripherals, so that smart device would capture the data from these different peripherals and transmit that to the portal so that we can view their data. I guess this is again an ongoing process. The good thing is that Singapore's internet setup infrastructure is superb. So we just need to leverage on that, and at the same time try to find ways to get into the homes where internet is not yet set up. For example, what we could do is use the TV setup boxes as the portals through which the peripherals can connect, because that's something you find in almost every home.
Okay, great. So one thing that came when we talk about technology adoption is also about the cost. So there is a question that says that because cost of technology adoption is also something of a concern, not just for the individual himself, but also probably for the institution like Eldercare, you may need to manage that. So how do you overcome the cost issue? So probably any one of you could actually address this. Maybe I'll get Gerard to also answer this question first, then followed by Dr. Kenny and also Dr. Ravi for the hospital perspective. Yeah.
To be honest, tech adoption is always a challenge in terms of cost and deployment. I mean, of course, the government, to be very honest, we do our part to support our providers. It was also during this period of time, during COVID, MOH has launched teleconsulting support for doctors and care providers who they decide to go on a teleconsult based on certain amount of time commitment. They will be reimbursed a certain amount. But I think tech adoption in the end, the value has to be seen both sides. As what I mean, the previous panelists have also alluded to, right? The person who is benefiting from the device has to realize that they want to benefit from it, and therefore they are prepared to step forward and say, I'm going to have an internet connection, I'm going to pay for the infrastructure for it. And then of course for the care providers, they have to see that by leveraging on the device, it is a value add that they can provide to their clients, and therefore justify backwards to their organizations to say, if we don't invest in this technology, then we will lose the opportunity to do other things. And I think this was very clearly shared by Prof. K. I'm using him as a live example now. And similarly, right, other care organizations that I've also spoken to during this COVID period, they realized that engaging their volunteers was absolutely important. And without the leveraging on the technology to connect back to their volunteers, when the what you call it, the relaxation or phase 2A, phase 2B came about, the volunteers will have all disappeared. And even in AIC ourselves, we do have our volunteers that are helping us in our what you call it, the senior, our SGO, Silver Generation Office, and we had to actively reach out to them during this period of time as well. So the conversation on value and technology is something that, to be honest, is also what we are learning at this point in time. As Prof. Ravin just now mentioned, right? The telehealth was tepid, right? That was such a big word, tepid, and it's very, very real, right? We've always been trying to say, get the seniors, can we use technologies? You know, you're based on the demographic, we understand that it's going to be very challenging, but perhaps we can adapt, right? As again, another speaker has said just now, we adapt. And then now during this period of time, suddenly we say that, well, this actually makes a difference. And therefore, collectively, we will have to look back and say, if it makes a difference, it means that there's a value. If there's a value, that means it's worth the investing. And then when it's worth the investing, then of course, question is where the money will have to come from. That's something that's a broader question as well. I don't have a direct answer, to be very honest, but I guess the first step is identifying that the tech has value to our processes. Yeah, thanks.
Okay. So how about Prof. Kenny?
I understand this is recorded, but I will take the risk, you know, how to make it sustainable. We go to folks like AIC, you know, and ask them for grants and funding. Of course,
that's true. That's true. But we do hope that agencies like the Comcare providers, that if they see value in this, and then through the their donations, that's why I highlighted a huge slide on donations, right? It's not, donations may not be sustainable on a longer term either. So I think this whole thing really has to have a retake and a rethink. It's something that I feel as well that the system will need to think about. Yeah, thanks.
Yeah. So I look at three ways of sustainability. One is the funding and grants, right, from the government agencies and foundations. The next one, of course, is donations. A lot of VWOs rely on donation dollars to do things that are actually not funded as standard service. But the other part, which Gerald already talked about, is the harnessing on the power of volunteers and partners. So we actually always look for common desires, right? Common passions and common vision to say that, hey, you would like to do this. We have the need. How do we match? So that's what's needed for sustainability. Is beyond the hardware. It's the people. You need people, at least for the transition interim, right, to make all this technology available. I always think it has to be a whole of society kind of approach. You know, we have to work together. One of the things which I think we really need to think about is how do we plan and design for the future. If we don't do that, whatever technology we want to introduce, right, is based on current infrastructure and current thinking. And there'll be a lot of abortive costs, you know, and a lot of adjustments that's needed, a lot of cost implications. And sometimes the cost implications will then deter progress. So I think while we are trying to repair a moving train, we kind of need to create another track to move as well. So possibly you need two tracks, right? Repair the moving one and create a new one. You know, at some point you then transit across. I don't know. Yeah, but I think there's a need to.
Thank you. So how about Dr. Ravi, from the hospital perspective, how is the cost managed and how you help patients to manage the cost?
Yeah, I think some excellent points raised by the other speakers. The way I look at it now is that introduction of technology, as I mentioned earlier, we're at the stage where we can almost virtually examine a patient. So in actual fact, by introducing technology, you can almost replace existing services and without any inferior outcome to the patients. In fact, of course, some benefits to the patients in terms of less traveling time, less waiting time, not being exposed to bugs in the waiting room, etc. Improve productivity for the staff and for clinicians. These are ways in which technology can then help to save on resource spending within the healthcare institution, as well as save costs to the patient. And then these can then be translated into spending for relevant infrastructure or devices that are required to enable these services. So, and of course, if we are replacing an existing service that's already subvented, you know, potentially at some stage, even these virtual services can also receive subventions, and they can be deducted via MediSave, etc. And these then again can be utilized by our patients in order to access these services in the way that they would be doing it traditionally. So I think that we are heading in the right direction. These are some of the things that our ministry is looking into. Obviously, there needs to be a cost assessment and there needs to be an understanding of the true business case. But I believe that as the data is generated through this COVID period, much more than we've ever had in the past 10 years, we'll be able to understand the dynamics of this and be able to come up with a platform that works for everyone.
Thank you. So maybe I will just ask one more question, which is on how do you measure the efficacy of the use of tech? Because again, we can only improve if we have a means to measure pre and post. So with all the implementations that you're running, do you actually build in a way to measure metrics to tell, yeah, use of tech did improve this much of the well-being and that much of the health? So maybe any one of you could want to address this question.
I guess I volunteer. To be honest with you, this COVID was a big push. I mean, whatever tech that I was sharing just now was something that we were trying to roll out and bits and pieces here and there. So the benefits, we are trying to work with our people who have received the tech and to ask from them what has changed. But very clearly, I think the early signs that have came back will be things like they really need to do the process change, or else they can't see the benefits. And for the seniors, well, those who have adapted, as I've said, they seem to be able to take on the tech, but yet interestingly presents other things. For example, when you have a tablet and a senior, actually one of the things that we try to avoid is to have social isolationism. And when you have a tablet and a senior, he likes that tablet so much, he's not going to give up the tablet. And then he doesn't connect with the people around him. And then that's one of those unintended consequences. So the measurement about efficacy, I know that Singaporeans we are very cost sensitive and very always everything there's always a causal relationship, right? I think it's a little bit further than that. Of course, if you look at tech in terms of rehab, then it's a lot easier to measure outcomes, right? As what Dr. Ravi was talking about, if you're able to do the chronic disease measurement outcomes, you are sick, you're not sick, or you are suffering from something, you are not. So it's always binary. But when it comes to psychosocial well-being, and we are talking about engagements, right? I think it's a little bit more challenging. I'm not saying that games like what they call it, the Harry Potter or the game that everybody stands at the corner of the street and play. Obviously, I don't play that, right? I'm not sure if it's better outcome for the society as a whole, right? So I think it's a journey. What is for sure staying is that the tech is actually on the table, so it's not going to go away. How will it change our lives? It's something that we will need to look at. Different groups of seniors will benefit differently. Obviously, the younger seniors, the newer seniors that are coming in every year, they will want the tech will be very much part of their life. Then it becomes like utility, whereas the seniors today, who are today our seniors, for them, it's a touch and go, to be honest. Yeah, I think that's my view. Thanks.
If I could just add on, and I'm just trying to share a slide. I don't know if you can see that. Just an overall view of the kinds of things that we are looking at when we run some of these tech programs. So, we look at access to care, see whether we can improve that. As you mentioned, cost benefit. We look at the patient experience through a variety of different measures, and even the experience of the provider. We look at how remote monitoring compares with standard methods of assessing patients' healthcare parameters, whether it's inpatient or outpatient. And of course, we look at the program performance overall to see whether or not it meets strict criteria, in the sense that the patient who undergoes a program like this should have either an equivalent or better outcome than what they would have had through standard care. So, I mean, this is just an example, but these are some of the things that we are doing for all of our projects to make sure that there's truly a benefit to the end user, both patients and providers. Thank you.
I want to just bring up the point I talked about being high touch to low touch, low tech to more tech. I suppose one of the things we then struggle with is Does high tech mean low touch? Can we do high tech and high touch, especially for the engagement part? And what does that mean? We probably then need to redefine, even for us, what eldercare means in an offsite, high touch as well as high tech kind of approach. And that, if you ask me, could be the new norm that we have, right? And yeah, I think we would love to work with SUSS, all your masters and PhD students to help us define that, and I think if you get academics in and kind of articulate, some of these measures, it will be fantastic for the way ahead.
Yeah,
Yeah,
thank you very much.
AIC would like to be part of that journey too.
Great. So yeah, indeed, we will be very happy to be part of the journey with you. And thank you very much for this morning sharing. It has been very insightful. So the key takeaway I can say is from this conversation is, first, tech has to be with purpose. You have to clearly understand who you're addressing. It has to also have the content that is engaging the people. And we should not assume that the elderly, the patients are not adapting to the new technology. And certainly, I think there are many things that we can do moving forward. And partnership is very important, both the private, public, as well as the people sector, to manage the cost, to manage the efficiency, to manage interoperability. So thank you very much to all my panelists today.